Well, so hey everyone, thanks for coming to XPC Talk today. And we're going to be with Jenny, who's going to talk about her experiences in technology and medicine. And I'll hand it over to her. She can tell us a bit about herself, and then we'll just learn what she's got to say.
Thanks, Claudius. And thanks for having me. I think let's see if I can, I'm having a hard time advancing. I'm just going to give a little intro about my experience. I grew up in Los Angeles and have spent the last 20 years actually in the Pittsburgh area. I came here as a ophthalmology resident and trained in oculoplastics and worked at then University of Pittsburgh Medical Center for about 15 years. So working at an academic center, I got to wear different hats. So saw patients, trained medical students, residents, and fellows, did a lot of research and also administrative things, and thought I was just going to sort of kind of hum along in terms of having an academic medical career. But then quickly realized that, even though UPMC at the time being a vertically organized, care delivery organization, having a health plan and as well as and venture arm, it was still really tough to make innovation stick. We worked a lot on telehealth initiatives early days, thinking about how to bring rural patients into Pittsburgh from a specialty care standpoint, and then just realized I'm sitting in all kinds of meetings without forward movement, so got super frustrated. And as part of my trying to balance my frustration, I decided to start a nonprofit with a fellow of mine at the time. And our goal was to be able to teach oculoplastic surgery techniques, provide resources to local eye physicians in global communities so that they can expand their capacity to care in the facial reconstructive sort of space. And our organization is called Project Thea, and we had a chance to then be in communities in Ghana and Kenya and India and Central America, which I will talk a bit in terms of that global perspective. And then also worked in the professional sports and kind of concierge med. And then in 2020, during COVID, I decided to make a complete pivot, applied to a LinkedIn ad, and took a job with Healthline Media. So Healthline is very much like WebMD, where we are a healthcare consumer information site and reaches about 100 million monthly visitors. And I've been in that company now for about 5 years, and we've become sort of a portfolio of businesses that has digital solutions to employers and health plans in terms of weight management and pharmacy solutions. We still have our media business where we have the health information properties. We have Healthline and Health Grades. And we also have a direct consumer product solution that we're building right now. And I say all those things because being in an academic sort of career to start with, and being a specialist, you had a certain view and perspective of how healthcare ought to be delivered. And being then in different spaces, especially being on the consumer side and actually seeing what people search for from an information perspective, and seeing how AI has, been adopted in the, kind of like, last 6 months to a year, and just being in different spaces for care delivery has really opened my perspective just in terms of the challenges that are within healthcare incumbent systems, and then what's happening in the tech world, and maybe there's a middle ground in how we think about going forward. And so, as Paulius mentioned, when he visited me in Pittsburgh, we had a walk, we were sitting around, and for those of you who know Paulius well, you know that he is very much one that's, kind of really think about ideas from various different perspectives, philosophically, tactically, whatever it may be. And he came with, markers and and wanted to whiteboard on lots of things. So we talked about, what does it mean in today's practice of medicine in terms of the push and pull that we're experiencing, both from technology standpoint, but also from medical culture, but also culture at large. And so this is a talk around that. And I wanted to share some of my perspectives, but also, like I said, want to make this a more interactive experience. And so feel free to interrupt and chime in. I want to sort of ground us in this quote to say that, Paul Farmer, who is a well-known global health advocate and started Partner in Health in Boston, has this quote where it says, with rare exceptions, all of your most important achievements on this planet will come from working with others or in a work partnership. And I think we have to think about technology and how we work with patients and work with others in the healthcare ecosystem, I think, in that way. And oftentimes, and depending on your experiences and perspectives, it feels like the clinical perspective isn't necessarily a equal partnership in the conversation with tech and other stakeholders within the healthcare space. And so I just kind of want to ground us that in that quote as we get started. As I was putting this together, I felt my own sort of kind of this, poll of, okay, can I use ChatGPT or Perplexity to pop in the question and get some thoughts going? And when we think about, what patients and what society from a culture standpoint want from medicine and what then is sort of potentially axes of synergy or clash. These are some of the kind of aspects that I came up with. And then in working with Polyus, and I felt like, well, maybe I should come up with my own concepts rather than just only using the AI tool in terms of concept. He pulled together this. And what model did you use, Polyus, when you pulled together this chart?
I have a shortcut on for ChatGPT. So this was like a one shot. I was like, hey, these might be some ideas, Jenny. And you're like, sweet. I find it. Yeah.
Yeah, and we certainly can, I think most of you are aware in terms of what have been kind of pushed onto the medical kind of community in terms of what patients are demanding and what they want, and mostly sort of in the last kind of 20 years in terms of abundance of health information and the convenience and access even in other parts of our lives that then make patients want that to also be their healthcare experience, and how that sort of dynamic then has changed a lot of how we think about care delivery and what it means for care delivery in the future. And certainly with AI and with payment models and just the complexity of how we think about our payment models, all those things are kind of at tension in terms of how we think about clinicians' role in healthcare and how we can, be a partner then in how we think about care delivery, technology, and how we serve our patients.
And Jenny, that you made some really good points. But I'm actually, as I'm reading this chart, like there's actually some things I don't know if I like agree with it. Like for example, on the reimbursement logic, I almost feel like, I don't know if I'm interpreting this right, but like they almost should be flipped because like I see if you think about like fee for service, CPT codes, documentation, and technology automates that. For whatever reason, the AI is analyzing it. There's a clash. Whereas here, to me, like this is the obvious thing to actually like supercharge, right? And so it's kind of interesting. Like I think it just kind of shows how even when AI reasons around these things, there's that whatever AI thinks humans would appreciate, there's still like it's not a one-to-one, sometimes can be opposite.
Yeah, and I wonder if this is a little bit of just that's the sentiment out there, and so therefore that's the output that the model gave us because
Yeah.
out there. And I wonder if that's the reason for that sort of arrival of conclusion. And we'll certainly touch on some of these things, but maybe not capture all of it, and would be interested in others' perspectives on this. But what I was going to go next is just around what I've seen from a global perspective in delivering care in Kenya, Ghana, India, and Honduras. And while they're, they all have very different sort of social norms and cultural beliefs. At the end of the day, it all becomes very similar, and the common ground around it. And partially, and I can go to the next slide, but partially, I think there's just scarcity in general. And because of the scarcity, you almost had to get super creative in terms of how then you built trust with your patients. And in all of the communities that we've been to, whether in Africa or India or in Central America, really comes down, I feel, to the essence of how we think about medicine and what we brought us into medicine. And that's really just sort of building the relationship and the trust between the patient and you. And there's just sort of not the extra layer that's added when you're delivering care globally, in terms of, an EHR or computer or technology that's in front of you, in terms of how you have to think about, well, can I make this recommendation and treatment plan? Do I need to know if this is going to be a covered, benefit for the patient? So there's all these sort of extra layers that are just stripped away, and because it's stripped away, that relationship that you're building with the patient is much more sort of, I would call pure in terms of how we think about the delivery of care, in the days that is not sort of grounded in necessarily how we think about the complexity of clinical care now. And because of that, it's really just about your interaction with the patient. So I think for all of us who go into medicine because we want to help someone, whether in an individual level or in a more kind of scaled way. We know how to interact with patients in a way that develops trust. And even though they may have different cultural beliefs in terms of how they think about Western medicine or surgery, they come to sort of believe your recommendations because you spend time talking to them, because you spent time understanding who they are, because you're spending time listening to them. And therefore, you develop that kind of trust relationship on this very individual level, that they trust the care that you're providing. I just find that to be sort of the essence of medicine that has a little bit of been robbed from us in the sort of US way. And that's just because there's so many layers that we have to think about, from a recommendation, treatment, and the interaction that you have with a patient. Whether you're constrained by time and your schedule, constrained by the administrative layers that are added to your clinic, constrained by how you can recommend a treatment plan based on the patient's socioeconomic status or their benefit coverage. And so all of those things, I think, are not there as the complexity layers for when you deliver care in a global perspective. And I find that to be just interesting from a cultural perspective.
Jenny, if I can add to that, and I don't know if you plan to talk about this concept of witnessing patients, but I feel like this was like a clip from some cheesy movie about relationships, but I think it so applies to medicine because it was along the lines that someone else just wants to be seen and witnessed, and it's like that's all, like that's kind of what makes up a relationship. And I feel like the layers that you're describing just make it really hard to witness people, and that's sometimes it's not even like necessarily fixing everything in the end. Like it's just there's that desire to be seen. Yeah. Yelena, yeah, feel free to say stuff.
Yeah, I don't know if this is something you're kind of come to later, so I don't want to jump in, but that's something I've been thinking about a lot lately as I think about kind of the role of technology in medicine. The work I do is, in substance use and mental health is really focused on relationship. Sometimes, quite honestly, that's all I can really offer people. Like the medicine part is the easy part. I can help someone detox. I can, get them on medications for depression. But the circumstances of their lives and the kind of the social determinants and, some of the chaos that has either or both preceded and followed their substance use or their mental health issue or things that I can't necessarily fix. And so I've been thinking a lot about, what parts of my job could technology do? Like it can get the information needed for a history. For purely diagnostic purposes, it could probably do that. It can make the diagnosis. It can probably make medication and other treatment recommendations equally well. But I think about like, where is the moment of care in the work that I do? And like, how does that show up? And I don't think technology can do that. And it's for that reason that you were saying, Polly, is that's a relational piece. It's bi-directional. It to me, that requires human to human interaction. And so, yeah, I think in an ideal world, we would have technology that kind of takes away those other layers you were talking about, Jenny, so that, like the carers, whoever they are, can focus on that caring bit. And, not so much on what's the reimbursement, do they have coverage, all of that kind of stuff.
And I feel like the humanity of care and how we think about what the doctor role used to be, or just the caregiver's role used to be, is not how we think about modern medicine today. And so if you strip away all of those things, and it's like, how are you witnessing the patient and how are you helping them? Most of the time, it is that relationship piece, and be interested in your view on just primary care in general. I feel like primary care at one point was that relational piece. You understood everything about that person, what made them tick, what stressed them, all of their aspects of their life, so that you can provide the right kind of recommendation that is outside of just giving them medicine, right? And that got away at some point where, primary care became sort of the gatekeeper to the specialists and whatever. And I feel like that is the push of just modern medicine, payment models, various things that added to this layer where we then are not realizing what it means to actually be that primary care. And that's the thing I think is interesting, as well as we think about what can technology do for us in such a way that we can get back to the humanity of what it means to care and take care of patients. Preston, I see your hand is raised.
Yeah, I think it's a great point. So I always want to ask myself, as a technologist, how can technology help support that as well? And this actually came up interesting enough during my I did a musculoskeletal start with an actual clinic, and the clinicians, and I asked the clinicians, hey, we're coming in, what are we asking them? What questions are you, before they walk into the clinic, they're answering on the phone to make sure they have the right clinician type, a bunch of routing stuff. What else do you really want to know? And they were like, well, it really helped me be more effective if I knew how to speak to the person, how they best react, what kind of personality. I spent a lot of time in the beginning trying to feel out how best to communicate with them to make them successful. And so we were able to add just a few questions that were sort of fun questions that got to a hint of what kind of person they were. So they walked in, the clinician had a little preview of, here's how I start talking to this person. Here's kind of how they're going to react. And they said, yeah, it not only saved time, it just made the more successful, right? Because they want to present the data, as you guys probably do, in the way the patient wants to hear it, the way they want to communicate, and let them skip the sort of careful dance of, let me figure out exactly who you are, with a little bit of a shortcut. Say, okay, I know enough. I can jump a little bit farther into the conversation, move a little bit faster, and spend more time doing evaluation and less time trying to feel you out in that first visit.
So like an icebreaker, basically, right?
Yeah, basically. And it was like we sort of dropped them in between the medical questions, so it felt a little bit less. It broke up the medical stuff a little bit, so you didn't feel like, just sort of feel like you're asking a bunch of, pain level, how to change, things like that. And they felt light, but they together produced just enough to give them a hint in the right direction.
Yeah, and that's a super interesting point to make, because you always think, how am I going to actually engage with the patient in that digital way, right? Whether it's asynchronously through a questionnaire or survey. I remember switching over to virtual care during the early days of COVID, and seeing a patient, whether a child or an adult, in their own home environment, and how do you build trust in these sort of various modalities of care, and so that's a fascinating piece in terms of how you then use technology to make that better.
Yeah. Preston, are you gonna tell us what the questions were?
I have to dig them out. It was like
Okay.
it was like 6 years ago now. I'm sure I have them somewhere in some file.
Yeah.
But they were like I feel like they're like, yeah, are you more this type of person or that type of person type stuff? Or do you rather like, read a book or go for a bike ride? Or would you rather, forget the other ones. They like that one because that helped them figure out, is this person going to be ready for some serious PT, or am I going to be very gentle when I suggest to get started, right? And just the ones that start getting hints like that.
Yeah, you're essentially trying to get an assessment of this person's personality before you give them a recommendation treatment plan. And when you're trying to do that digitally, whether through these asynchronous questions or not, you don't have the nonverbal cues as if you're in a clinic space with someone. And so I think that's just that's fascinating. And I wonder if that could be applied to the LLMs going forward, in terms of having an LLM, understand you more before they give you a certain recommendation.
I also really like that because I know a lot of the like scribing technology right now, there's conversations about like, what do you keep in and what do you filter out from the conversations, and kind of what's lost when you filter out all of this contextual information, like that this person likes to go on bike rides, or, they just got a new job, or, stuff that, the context that depending on how the model is set up, might see as fluff or kind of extraneous because it's not that pure clinical information, but that actually really serves primary care physicians really well, because those are the pieces that, you refer back to your notes before you see someone that you haven't seen in a few months, and you see, oh, right, like they were doing this the last time I saw them, and you just ask them a question about it, and that, helps them to feel seen and that you have that relationship.
And I feel like that context is important. And if I may share a story here, which is oftentimes when medical students and residents go on these trips with us, they're so used to having, recommendations that they just say. So after a procedure, they'll say, have some ice pack, put it on your incisions to help reduce bruising and swelling, take some, ibuprofen, whatever the recommendations are. But you imagine in sub-Saharan, Africa, Kenya, like there are people who don't even have running water when they go home from a procedure. So certainly they're not going to have ice, nor are they going to get ibuprofen. And it makes you think in terms of, oh, do I make these recommendations because I'm in a totally different environment now? And that's the context I think is important. And just like Elena, you were saying, from a primary care standpoint, you want those contexts. I remember the days of like, paper charts where you write little things in the bottom of like, oh, this person takes care of her grandson, like, so, and that's his name, and make sure you ask about it, whatever it may be. Like, those are the things that I think sometimes are lost now, because that's just not the focus.
If I can also add, there's this article about chit chat and how the scribes take that away. I'll put that in the comments, and if someone doesn't have the link, I can send you the actual article. I put it in our Slack chat, but it's actually, I know the person who wrote it because I used to work with them in Boston, and they were always the grumpy person, challenging the bureaucracy. And so he worked actually closely with Paul Farmer because like the offices were in the same place. And I actually remember people were disagreeing with him, and this is still like a hot topic, I think, among physicians, but like some of his patients couldn't afford, they lived farther away and they couldn't afford a bus fare. And so he would just give them a couple of dollars. And people were like, what are you doing? This is bad. But he's like, I don't care. Like, this person needs it. Like if I can help out, so anyway, I think it's cool to see these people still like carrying that torch of humanity and reminding people that tech has a role, not the role.
I was going to switch topic a little bit and just sort of talk about how culture then actually impacts disease prevalence. So being in these global communities, we actually encountered, sort of what globalization and global commerce means in other communities. So the export of American fast food culture is rampant in all of the communities we've gone to. So, Burger King, Pizza Hut, all of the kind of global fast food chains are in all of the countries I mentioned. And as a result, the changing of the diet has changed metabolism and it created new disease entities that are actually not ever seen in those communities. So in Ghana, pseudotumor cerebri in young female patients became much more, and they've never seen it before. And so when somebody comes in complaining of headache in that population, they're not necessarily thinking about looking at the back of the eye and checking for papilledema. And as a result, there were lots of these patients who then delayed in their diagnosis and then have lost vision. And it was presented as a sort of a huge case study of, kind of like an MMA rounds at a African Ophthalmologic Society meeting where they talked about sort of the export of American fast food culture into these communities, changing their metabolic state and then causing disease that's not ever seen. So I just thought that was interesting from a how we think about these kind of unforeseen hand at play that just changes care in general in these global communities. In digital living, we're during COVID, everyone was on a screen and would continue to be on screen time more, especially in that young age where the visual pathways are developing and there's so much of the growth of the eye during that time. And so the rise of myopia is so high in children. And we don't really have a good solution for how to decrease myopia rate. So these are just some things I call out from just a perspective of what happens to medical care and condition onset from society and from culture and society as we go through various different phases of living with technology, living with our fast food culture. So I just wanted to kind of point that out. Comments. Then what I was going to talk about is sort of just the tech from a global perspective. And certainly there's not reliable Wi-Fi and everything is based on 5G. And so mobile applications are much more utilized compared to web-based applications. And EMR systems are hardly around at all in some of these global communities. But that doesn't actually stop them from thinking about quality and data metrics and reporting. And I have the picture I share on this slide is actually a community hospital in Nairobi, outside of Nairobi in Kenya, where you can see they're tracking maternal mobility and mortality rates in this board that they created. And it's not any different than how we think about tracking of complications and quality metrics within our EMR. And so just because they don't have the technology, they're still thinking through all of the kind of quality metrics. And I share one of these articles or this journal in terms of they started thinking about a health management information system in a mobile way, where you're supposed to use your phone and use through an app, you're inputting some of the maternal and fetal mortality and mobility in the region of Ghana. And they realized that was actually a blocker and a barrier. And because people were so used to the traditional ways of using, paper, using, analog versions of this, that even though they had a phone that they used for everything else, whether it's consuming, information, being on social media, whatever it may be, they couldn't think about it from a work perspective. And so I thought that was a fascinating kind of view into just, we talk about the push and pull of technology in medicine, and even just, I think in the US, oftentimes there's resistance in terms of how do we think about technology in our workflow, and how do we think about technology in our day to day, and this is not just only applicable here, but also in global communities where even though technology is adopted for everything else that you use in life, to convince a healthcare worker to actually document using a mobile application took a lot of education and training.
I also saw the same thing when I was in Honduras, and there's like obviously, I feel like no one really cares about patient like privacy as much as like it's also a cultural phenomena in the US, and it's like, I mean, it's important to not spill your beans, but I guess maybe like people just don't seem to be like worried about that at all. And I don't know. Yeah.
And I think it's one of those things where it almost is better because you don't care about because there's not this culture of worrying about privacy. We had 3 patients in one room all being taken care of at the same time because that's how you had to get through, because you had lack of clinical space, and you had to get through the volume of patients. But also we tried using because through our nonprofit, we made a web-based platform where we, implemented Slack. We implemented a whole bunch of different technologies stitched together to kind of stay connected with our partners. So say, hey, if you have a consult and you want us to give you some, curbside recommendation, use this, Slack on, or use the Slack channels, or use the platform on our website. But they were so used to using WhatsApp as a way for communication that they just couldn't adopt to, even though we gave them a login, we showed them how to do it, they just couldn't do it. So every time they would still just WhatsApp us in terms of sharing the patient information. And while WhatsApp is a bit more end-to-end encrypted, it just didn't matter. It didn't matter for them. And so again, this behavior change in terms of what you're used to and what is asked of you new is this interesting phenomenon that I think from a tech adoption, and this is why I think there's so much promise of like, what can tech do in healthcare, but it hasn't fulfilled those promises.
I gotta say, it's very true in the US too. I was actually most recently working for a company that did low-code platform for building workflow tools for like a lot of mental health support, crisis team dispatch, tracking, things like that. One contract we won was literally a state of Missouri mental health organization that signed a contract for a piece of software to do all this, $1 million plus, whatever. And after a year, had tossed it and came to us to build the next one because they refused to use the software, the clinical teams. It didn't support the workflows the way they wanted to do it. It was, in the abstract, better, right? It did let you track things digitally rather than paper. You had more records, you would track things, but it did not support the pieces of functionality that they felt were very important. And it was very specific to them. They had, there's obviously a big rural population. They had 2 or 3 dispatch teams been injured by farm animals loose on property. And so they want, very important to them, a required question to ask about that before dispatch. This other system didn't support it. There's no good way to train everyone to ask for it once it's in a flow. So they just rather stick in the paper form until they get a system that can support it, right? It feels stupid. It feels like, come on, guys, you got so much other value out of this. It's so much better, or compare, but no, that was so important to them that they refused to use the software they previously bought, or the managers had bought, until they got tools that actually supported the way they wanted to work.
Yeah, and that piece, I think we don't account for when people are selling technology solutions, and when this is even for people who understand potentially clinical workflow, you're still you still can't sort of predict what people are going to do from an adoption standpoint. So yeah, totally to your point, Preston. I want to shift a little bit just in terms of, I think we talked about the changing patient-physician dynamic, especially in the US. And this is a kind of a question posed. I mean, as a clinician, I knew that people were coming to me with all the Dr. Google things that they've been searching for. And I saw the shift probably in early, I don't know, 2015-ish time, where more people are coming in with information and wanting to talk about that information instead of taking your recommendation as the authoritative figure. And now being on the side of a company where we're actually producing all of this information based on Google search and what people are looking for, and writing content from a SEO perspective. It's a fascinating sort of space. You see what people are searching for, and people search so much on symptoms, and they search so much on how they can manage things outside of the traditional walls of care. And that has given me sort of a perspective on, we oftentimes, especially coming from an academic environment, we oftentimes think of ourselves as being sort of this white ivory tower, right? We're the experts, we have all of the information, and we're going to sort of, give you that information. And seeing what then that has potentially cause as a push for people to not really seek healthcare the way they ought to be, and where they're just thinking about self-management, has been a fascinating kind of dynamic for me, being on this side of things now, because oftentimes people are looking for how to take care of something themselves, the DIYs of health. And I don't know how we sort of make that better, especially in the world of misinformation, and how people are seeking healthcare and recommendation and advice in social media. So that's just an interesting phenomenon that I'm seeing, and I think as clinicians and as sort of what I call the traditional healthcare deliverers, we ought to be thinking about how do we bring our solutions more upstream, so that it doesn't create this silo or this schism, or further schism of patients thinking about things over here separate from how we are delivering care in the traditional way. And I wonder if this is, again, a reimagine of what primary care ought to be doing for the future. But be interested, Polyus and Elena and others on the call, in terms of your perspective on that too.
I actually wanted to ask, I guess just with like the recent obsession with health and wellness and overall, just like, I feel like now in the past, even like 5 years, people have just become so obsessed with like taking care of their bodies, and I think that goes really hand in hand with what you're talking about, is just like learning about what are like ways to make myself healthier, like vitamins, supplements, like all these other things. Like, do you think that, because like objectively, maybe to some like average person, that seems like a good thing, right? So do you think that is like an overall positive trend? And, like, how do you see this, what you're talking about, like interfering with that?
Yeah, it's interesting because certainly, you see so many health and wellness practitioners out there, mostly because as patients come to talk to their physician about potentially alternative therapy or nutrition or fitness or supplementation, oftentimes a clinician will dismiss it or say, hey, there's not enough evidence and therefore we shouldn't think about it this way. Or clinicians who've been in practice for a while often don't feel equipped to have the knowledge to be able to discuss nutrition and fitness and supplements in a way. And so I think because of those kind of potentially knowledge gaps or unwillingness to sort of address that, I feel like there's a schism out there in terms of people wanting to have that information for their clinicians, and then the clinicians are not necessarily giving that recommendation or advice for whatever reason. And then therefore people are going to kind of other health and wellness, whether it's influencers or practitioners, to get that advice. And it's creating more and more challenge, I feel, because oftentimes, you have lots of people promoting supplements, and I'm sure we all have our perspective of what it means to be heavy in supplements. But there's real danger, right, in terms of drug to drug interaction, if people don't understand that they're also, impact of supplements, with other medications they take and whatever not. And so I think it's a thing that the clinical kind of community needs to address. And I don't know that we're addressing it in such a way that's helpful for a healthcare consumer or patient. Elaine, I see you nodding, but I wonder if you guys agree with me in terms of there's just too much noise out there, and we haven't really, as a clinical community, sort of taken on that kind of burden of saying, hey, this is what we ought to be thinking about with patients and healthcare consumers.
Yeah, I was just going to say in response to that, I think my like generation of like trainees, like people who are still in med school right now, like there's just been this huge push to incorporate more like nutrition in medicine, types of like interest groups that kind of, I don't know, there's just been this sentiment that we're like physicians are not being taught enough about nutrition and things like that. So it's, you know, there's like an interest group at my school that's like really, really all about like lifestyle medicine, things like that, and just trying to get more experts to, because it's hard to incorporate something entirely new into a curriculum when you're already like jam packing your first 2 years of med school with so much content. So it's like unreasonable to ask your med school to like add something on top of that. So yeah, I guess just do you kind of agree that that should be incorporated more into like medical school curriculum?
I do. I think that should be incorporated more into the curriculum. And I think there's an association of lifestyle medicine where, people who've been practicing medicine for a while can certainly get more CME or, education around that. I think it's important. I think it's important to be able to, again, treat the person as whole. And as what Paulius was saying before, just in terms of witnessing and be able to see the patient as a whole instead of just treating what they're coming in with. And I think that helps, again, to develop the trust with the patient. And it helps to what I call sort of almost win back some of the kind of, prevention, longevity, health and wellness topics that then are outside of the clinical realm. And I feel like this is what primary care used to be about.
I think you're asking great questions, Aditi. And if you ever want to connect with more of the lifestyle physicians, we have a few folks in our Slack group that enjoy talking to others and are pretty into it in their own way, and that comes with different biases as well. Mm-hmm. I think one thing I would add to this conversation is, I think about how technology just changes our role, and often helpful to look at it through the lens of information asymmetry. And I mean, I'm in the camp that I'm all for patient empowerment as a just directionally the right thing to do, because we're all patients and like we should be empowered. And Clay Christensen is this business author. He's written lots of interesting books. One of them is called what is it? Innovation Prescription, something similar along those lines. Innovator's Prescription, and in it he talks about how disruption happens in healthcare, and I think this is kind of relevant here on the theme of like how do roles change. So basically, doctors used to be the ones that held all this special knowledge, and then people could get access to up to date, and so people who supported doctors, like nurse practitioners and physician assistants, used to be more in the role of deferential to those who knew more, so to speak, at least through the training route. And now with that, their roles have somewhat equalized in different ways. And we can see like regulation granting nurse practitioners practice authority to be independent without physicians. And then what's happening is then patients now are getting access to information that was not available to them in the past. So then they're somewhat like disrupting the group that was somewhat upstream to them, and or downstream, however you think about it. And so I think in the end, like if the patient ends up being the one with the same knowledge base as physicians, then it's like, how do we support them in that? And I think that role really changes. Anyway, that's a framework that helps me think through this. I don't know if that really answered anything, but it's just like good for thought.
No, for sure. And 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 again, it comes to sort of what I mentioned in terms of patients demanding more convenience, right? And just the consumerism of healthcare. And you see that in terms of where care is being moved into all the different spaces that we haven't thought about. And so retailers like a CVS or Amazon are providing care. Influencers are technically providing care in how they're making recommendation. And there are many pharma companies that have gone direct to consumer in terms of GLP-1 access and whatnot. And I think all of this becomes more as we go forward because the incumbent sort of healthcare systems have been challenging in terms of how people can, get access, and what Polly has mentioned in terms of that changing in the dynamic, in terms of the roles we play in that patient and caregiver, and as a result, people are sort of just starting getting care everywhere, and in a way. Technology also plays in that sort of care giving way as well, as we think about LLMs, and you hear people actually taking all of their lab reports and imaging reports and feeding it into ChatGPT and getting recommendation there. And so that wave is coming to us from thinking about how we deliver care, and I think it's important for us to have as clinicians to either say we are willing to kind of play in these different, being in thinking creatively and playing in the different spaces of care, or we can say we're still going to be thinking about it in our traditional way. And I don't know what the right answer is, but I see it in a way that feels like we're becoming more fragmented and siloed then from how we provide care in the traditional sense to how care is delivered in non-traditional sense. And so that's just the culture, I think, pushing what then needs to change from a traditional medical care standpoint. And I just don't think we necessarily have had the right solutions for it just yet. And I'm interested in sort of how we almost kind of, take back a little bit of, well, could this just be what the reimagine of primary care be? So.
You gonna cause a revolution, Jenny?
Well, this goes towards like sort of, when we think about this, how many medical clinics are there in the U.S.? There are about 31,000 in the traditional way. We have about 2 or 3x of gas stations compared to medical clinics. And with the aging population, with the demand for convenience, and with sort of not having enough care providers and care deserts popping up everywhere, I don't know what the right solution is, but maybe it's technology. And if it's technology, how do we use technology in such a way that can, sort of have the adoption? And I was actually gonna go to the point of creative. I'm just gonna go here, the creative destruction, and the economist's view on sort of if things are changing, right, and you have the changing which is happening in the medical economy, when there's change that's happening, there's always going to be a period where you need to upskill the workers, and you have to sort of reorient the capital and resources in which how you think about the change. And I think that's coming to us in terms of the consumerization of healthcare, and the need for it to be convenient. And I don't know how we sort of contribute to this revolution in a way that feels like we are owning the care part back, because otherwise we're going to watch this happen, and we're going to have lost control of it. And this is the quote that like I think about in terms of it's not one single spectacular event, but they're just little things that have been pushing the healthcare incumbents in such a way, whether it's technology, whether it's consumer demand, whether it's the changing dynamic of having information in this somewhat equal way, and how do we then think about that push and pull in terms of reimagining what care could be.
This is great, Jenny. Thank you for having us think deeply about this topic, and just I think you guys shared a lot of cool thoughts. We have a couple more minutes in case anyone wants to add anything on top, but just huge thanks to Jenny for taking the time to collect her thoughts. This has been good.
Yeah, thanks for having me that way.
Thank you so much, Jenny.
I feel like that was a really beautiful wrap up, Jenny.